Good afternoon, everyone. Happy to be here with you this afternoon and happy to be a part of this Live Well San Diego Advance. And we are here this afternoon for the session called Building Strong Networks of Care to Address the Impact of Adverse Childhood Experiences. So welcome. I am Kitty Bailey. I'm the Executive Director of the San Diego Accountable Community for Health and will be one of your speakers today. We also have with us Pradeep Gidwani, the Medical Director for Healthy Development Services, First 5, and the American Academy of Pediatrics, Chapter 3. And we also have Lori Clark, who's the Chief Program Officer of the Social Policy Institute at San Diego State University, and you'll be hearing from each of them through the course of this hour. I wanted to provide a little bit of context and background before we jump into our speakers. So our learning objectives today are really to increase your understanding of the clinical and community perspectives related to ACEs and discuss how we would enhance clinical community linkages through building a network of care. So the things you'll be hearing about this afternoon include what are ACEs, what is the prevalence of ACEs, how would we go about addressing these, and what are the ways we can work together in new novel partnerships to really address ACEs comprehensively with strong community clinical linkages. ACEs Aware is an initiative that was launched in 2019. It has a bold goal to reduce ACEs in California by half in one generation. It is led by Dr. Nadine Burke-Harris, our California Surgeon General, and Dr. Karen Mark, the Medical Director of Department of Healthcare Services. ACEs Aware has received state funding that they utilize to train, create screening tools, protocols, and payment for screening children and adults with ACEs. And they've deployed a 12-month grant program that can support additional training, communications, and enhancing strong local, what we call networks of care. In June of 2020, this past year, ACEs Aware awarded 100 grants across the state to work on these projects. In San Diego, we were fortunate to receive several of these grants, and what we have here listed for you is a list of the current awardees in San Diego County. This includes the San Diego Accountable Community for Health, American Academy of Pediatrics, Chapter 3, the Social Policy Institute, and the YMCA. You can see listed under each of those organizations is the type of grant projects they received funding for. Today's presentation is really going to bring us to a point of a shared understanding around what is a network, an ACEs trauma-informed network of care. The ACEs Aware initiative defines a network of care as a group of interdisciplinary health, education, and human services, as well as community members and community-based organizations that serve families, with the goal of providing resources, supports, and services to address toxic stress and the outcomes of ACEs. There is a recognition built into this definition that it really requires cross-sector partnership and collaboration to comprehensively address the adverse childhood experiences. With that context and background, I'm going to turn it over to Dr. Gidwani, who will give us a good overview of ACEs and the full spectrum of what we're looking at here today.
Good afternoon, everybody. My name is Pradeep Gidwani. I'm a pediatrician by training, and I do a lot of work with a number of First 5 funded programs, as well as this new ACEs Aware initiative. It's very exciting to have the opportunity to work collaboratively. And as you saw earlier, our organization is educating pediatricians and helping them get screenings happening in their offices, as well as working with our partners to make sure that when we identify folks that they can get the resources that they need. We were joking about how this format is actually kind of tricky because I don't get to see your faces. So I don't know how many of you have an understanding of the ACEs. So I'm just going to do some broad overviews of the Adverse Childhood Experiences study. This was a groundbreaking study that was actually done in 1998 by an internal medicine doctor here in town, Vincent Folletti and Robert Onda from the Center for Disease Control. What they found was when we look at categories of abuse, neglect, and household dysfunction, they put together a screener around this, and they screened 17,000 families, or I mean 17,000 people in a period of time. And what they found was really quite incredible was when we looked at these categories, and these were just, do you remember these experiences growing up? When they looked at these, we saw a real connection to health outcomes. So the more of these that you had, the more likely you were to have health risk-taking behaviors as well as health issues. And we'll get to those in a minute. And on our next slide, you'll see that this is actually very prevalent. And this is just looking in California and looking at the rates of folks with, and again, that in purple of more than 14 is, more than 4 adverse childhood experiences really correlates with health outcomes. And we'll see that in a minute. But 62% of Californians have at least one ACEs, and 16% have experienced 4 or more. And again, I don't have all of the data about all the health indicators, but it really is staggering when we look at this, at the amount of health impacts. Now, what's so important about this study, and really what's so groundbreaking about it, is it really helps us see the connection between mental health and early childhood experiences and overall lifetime health. And so the Surgeon General's just really bold goal of changing health outcomes in our whole state is an amazing endeavor. And so we're very excited to be part of this. And so just to give you an idea of what we think is happening and what the mechanisms are, on the next slide, we talk about 3 types of stress. So when we talk about stress, we don't want to make it out that stress is such a bad thing. We all need a little bit of stress. Think about learning how to drive a car. The first time you're learning how to drive a car, there's some stress there. Anytime we're learning, there's some stress, and we call that positive stress, right? So that's brief. It increases your heart rate. There's a mild elevation of your stress hormones. It gets you really alert. Now, interestingly enough, there's also tolerable stress. So it's serious, it's temporary, but it's also buffered by supportive relationships. And that's one of the key things we'll keep coming back to is how important supportive relationships are to helping with stress. And the stress that we're most worried about, and the stress that really is having the impact when we think about adverse childhood experiences, prolonged activated stress with the absence of protective relationships. So in that case, you can see where that will have an impact. And on the next slide, we can talk a little bit more about what are the biological mechanisms for that. And this is a bit of a busy slide, but if you pay attention to the middle, what we're really pointing out is that there's changes in our nervous system, so the way that we perceive the world. There's changes in our hormones and how, again, stress impacts us. And then there's also changes in our immune system. So the combination of those changes of both of the nervous system, the hormonal system, and the immune system really leads to clinical implications. And so you'll see changes in actually how genes are expressed. It really has a big effect on our inflammation. So there's a lot that happens. And so when we go to the next slide, we start looking at the actual conditions. And so what we've seen is that ACEs really dramatically increase the risk out of 9 of the 10 leading causes of disease in the US. So if you look at it, the odds ratios are the more likely that you are to have heart disease, cancer, stroke, Alzheimer's is quite strong, diabetes, as well as kidney disease and suicide is very significant. And again, look at that suicidal risk. It's a considerably high number. So again, what does that look like? And so in this next picture, we see what does it look like for children? So I'm a pediatrician. I'm very focused on kids. And if we look at how kids are impacted by early trauma, we can see it has an effect on their working memory, an effect on their ability to inhibit their response, so the ability to regulate, and also on their ability to be flexible in their thinking. So when we look at it, we can see it in toddlers and infants, we can see it in school-age kids, and we can see it in adolescents. And I'm not going to get so into the details here with this, but again, you can understand this really changes our whole way when we think about ability to learn. If a child has this underlying stress and this inability to regulate their emotions, you can see how this will have such a significant impact on the way that they're able to learn. And again, I think this is such an important aspect of how we think about the way things work for kids overall. This is just again this is again important to show how early adversity has lasting impact. So you can see this whole list of pieces, but if we look at it, the data shows that with suicidal attempts, it's 37.5 times more likely. Alzheimer's we saw was 11.2, as well as chronic diseases. But it really has impacts all the way across: alcoholism, school, the ability to do well at work. All of these things are very strongly impacted. So on the next slide, you can see what we're actually trying to do with screening. What we're trying to do is we're actually trying to improve healthcare. In the past, we in medicine have labeled families as non-compliant or patients as non-compliant. And I think we have to rethink that. We have to think what's going on so that we can better support individuals and families' well-being. Also, we can reduce the long-term health costs. And also we can help detect other issues. In addition, we really have a big impact on prevention and early intervention. And if this all plays out like we think it is going to be a dramatic increase in the health of our population, as well as their ability to express themselves. And finally, and I think what's really interesting is really kind of normalizing and reducing the stigma. For most people who have experienced trauma, they think it just happened to them. They feel very isolated. So again, part of our effort here is really to try to make people understand that while their experiences may be difficult, they're not alone, and help break down that isolation. Because again, it's through supportive relationships where we can really have an impact. And so on the next slide, we're really trying to work into our work as pediatricians, and we're trying to get our colleagues in adult medicine as well to join us in this effort. But we really want to affirm people, their experiences. And we don't actually ask them, did you have a traumatic experience? We ask them, what was difficult in your early life? With the whole idea that it's not what's wrong with you, it's what happened earlier in your life that's still affecting you. So we want to be able to affirm their difficult experiences. We want to be able to educate. We want to be able to assess and validate and empower. We want to make sure that we refer them. And sometimes the referrals aren't necessarily to mental health, but to other ways of supports. And we really want to make sure that when we do hand people off, it's a warm handoff. That's what the whole idea behind networks of care are. It's the whole idea that if we know who in the community is doing work that can support families, we want to be able to make sure that the family gets there and those barriers are removed. And we want to follow up on those referrals. And as primary care physicians, we're going to make sure that we follow up on that. So this is a whole kind of new level of work. And some of my colleagues have actually said things like, well, you know, that social work type stuff. And again, I think the important part is to understand that supportive relationships are really important for families and patients to be able to follow through with care. Now, on this slide, what we're really doing right now, working with clinical teams, it's not just the pediatrician or the doctor who sees the individual, it's the whole clinic. And so we have to really prepare the whole clinic from right at the front desk. And what we're trying to do is make sure that we're not re-traumatizing. You might hear talk about trauma-informed care. And so some of the key principles in trauma-informed care is that sense of safety, that sense of really having the patient feeling heard and seen, and that really sense of caring. And so again, I think our systems in San Diego are really working hard to make a difference in normalizing the whole screening process, normalizing trauma. We're really working with our pediatricians to be empathetic and supportive, and really also assessing the family's readiness. We have already, in the preliminary work that we've done, we've seen that some families are ready. Some families hear this for the first time, and it takes them a little time to process. But one of the most amazing things that's been happening for us in pediatrics is we're seeing so many parents who realize how they were raised isn't the way they want to raise their kids. So they're very motivated to change, and they're very open to change, because again, when we do this, it's really in a non-threatening way. We really make sure that people understand it's for everybody. And again, the goal is not to delve into the deep impacts of the trauma, but to assess what kind of supports and services they need. And you can see here with the family readiness, we really want to reduce sources of adversity, and we want to match the right resources with the right needs at the right time. And really, we want to enhance the sources of buffering. And so, again, we think about this in terms of Maslow's hierarchy. I think all of us are very familiar with Maslow's hierarchy around making sure that people feel safe, that sense of belonging, the self of esteem. And so, again, we really want to be working along those ways. And so, the way that we do that, on the next slide, you'll see, is really through self-care and stress busting. And so, again, this comes from the work from the Surgeon General's office. And again, right at the top of this, you can see mental health care is there. Not everybody's ready for that. Supportive relationships. So we work a lot with how do we enhance those relationships. But you can also see quality sleep, nutrition, physical activity, access to nature, and mindful practices are very, very important. And so what we really have done is try to work with our providers to really come up with individual care plans. So if you can see on the next slide, some examples of just our self-care goals, and this is really helping to empower families. So we have these beautiful materials that are available even on our website, and we're really working with our pediatricians and with other providers, family practice doctors and internal medicine doctors, to think about having this as part of their care. So on the next two slides, we really want to start talking about the future. And one of the things that we've really seen is this emphasis on adverse childhood experiences is looking at risk. But we also want to look at resiliency. And a colleague of ours, Dr. Bob Segi, who's in Boston, has come up with looking at health outcomes through positive experiences. So HOPE stands for that, positive or health outcomes through positive experiences. And he's really done some great research that shows that relationships, environments, engagement, and social emotional development are very critical for folks that have had high ACEs scores who end up doing well. So they went back and they looked at interviews of individuals who had high adverse childhood experiences but did well. And they really found that supportive relationships, safe environments, engagement, that sense of a child having a sense of belonging, whether it's through sports, whether it's through having a coach that cares about him, a teacher that cares about him, is really critical for that help. And then opportunities for social emotional development, and playing and learning with peers and collaborating in arts, music, and drama. So these are the building blocks. This is where the network of care becomes important. We're going to really look at how we can build those safe relationships and healthy environments and engagement for both parents and children. And while we talk about social emotional development for children, truth be told is social emotional development for adults is very critical as well. We want to have those opportunities for parents to grow, for adults to grow. And on the next slide, we really see what I think is so critical is again, ACEs are not destiny. So adverse childhood experiences, they're just a place to start off. And we want to normalize the idea of screening, and we want to educate and motivate people to address what's going on. And the thing that I want to leave you with is a really important concept, which is really called post-traumatic growth. One of the important parts about trauma is not the trauma itself, but what we do with it. So much art is created. If you look at the art that's out there, so much art is really the resolution of pain and trauma. And there's so much great art that has been created. So you think about it from that perspective. But also, when people go through difficult situations and they're supported and they have folks that help them and they build skills, often we see incredible growth that comes out of it. Some of the most compassionate human beings I have ever met are folks who had very, very difficult childhoods. And it's just the amazing part of the human spirit to be able to watch an individual who, despite a very difficult upbringing and a very difficult childhood, ends up becoming a deeply compassionate, caring individual who really makes such a huge difference in our community. So again, while it's important for us to look at the adverse childhood experiences, they are not destiny. And in fact, that post-traumatic growth is really, I don't know how to say it other than it's inspiring. Some of the most inspiring human beings I've ever met are those individuals who have really overcome adversity, whether it's early in life or later in life. So again, as a society and as a community, if we can find ways to promote people's opportunity to grow, it's really the greatest opportunity we can have, and really does fit with the whole live well perspective. So with that, I'm going to pass it over to my colleague, Lori Clark.
Thank you very much. And I'm Lori Clark. I'm the Chief Program Officer at San Diego State University Social Policy Institute. Just a little bit about the Social Policy Institute. Our goal is to bridge academia with government, business, and the community to increase well-being in children, families, and the community. So our mission here at SPI is very well suited to partnering with the folks you've heard from already in support of the ACEs Aware initiative. Next slide. In addition to being that bridge to academia, we also champion integrated learning systems. So as a university, we work with organizations, communities, whole counties to infuse a shared understanding and shared learning about some of these principles, practices, policies that are so fundamental to being able to activate and motivate change. We also are very forward thinking in facilitating partnerships, and partnerships that are designed to balance results, process, and relationships across the board. And then finally, we are focused on getting research to practice quickly that lifts up the notion of diversity, equity, and inclusion. So today I'm going to talk just a little bit where Dr. Gidwani left off about what we do in the community from a community-based perspective in terms of bridging the screening and response to ACEs into the community. So on the next slide, you'll see that we feel that one very strong community-based response to adverse childhood experiences is to strengthen families by building protective factors. There are at least 5, if not more, evidence-based protective factors that have been identified. And we know that these are characteristics that all families need to be strong and to thrive. So the first one is concrete support in times of need. So this matches what you heard earlier about Maslow's hierarchy, where there may be a traumatic need, there may be a prior experience. Those concrete life needs must be in place to support an individual or a family being able to respond to that. Social connections are another. We can't say enough about the value of positive, supportive relationships. And we find that the community is often a bridge to helping to facilitate that. Social and emotional competence of children is important to recognize in terms of being clear, what are those markers of development? What is age appropriate so that we can support parents and caregivers in their role of raising healthy children to thrive. Knowledge of parenting and child development, of course, is a part of that. And then finally, parental resilience, which is the ability to do well in life and to care for and nurture one's children safely in spite of having been through adverse circumstances. So what is it that the community-based organizations and resources can do? So on the next slide, you'll see a few things about community-based organizations and their role in responding to ACEs. First of all, they are known for providing programs that build and strengthen protective factors in family. It's the heart and soul of what community-based organizations do. Secondly, they're organized around engaging families and residents in a trauma-informed way. So in a way that does not re-traumatize, that's safe, but that's engaging and relationship-based. Thirdly, community-based organizations are there to conduct a more comprehensive assessment of the entire family strengths, assets, needs, opportunities across the board as a part of better understanding what might be helpful to that individual or family and how to match them to available services. Part of that assessment is providing also a linkage, not just information and referral, but a means of developing the skills and capacity for being able to access supportive services and be able to engage with them and benefit from them. And so in these ways, the community-based organizations can be a very meaningful part of the referral pathway. And I'd like to say just a little more about how they go about that. So this is where the network of care concept comes in. These local networks of care are basically designed to bring pediatric practices and the community organizations together on a local level. Same neighborhood, same sort of ability to share and work with the same kids and families. And so what we are currently doing with the local networks of care is, first of all, inviting pediatric practices to meet community-based providers and hear about how they approach supporting children and families. So in this way, we open up the opportunity to ensure that the pediatric practices understand what it is that community organizations do, how they build protective factors, how they alleviate the kinds of challenges that you see that rise up out of adverse childhood experiences. And I will also say that most community-based organizations see themselves as having a dual role in not only working one-on-one with families in a positive, supportive way, but also in working to change the conditions in the community that can lead to some of those adverse experiences. So we bring the pediatric practices together to better understand CBOs, community organizations, and at the same time, we want the community-based organizations to better understand the needs of pediatric practices. So what we are hearing as we're bringing folks together is a very dynamic exchange around the nature of the work that is resulting in the desire to have ongoing communication, to make a warm handoff, to have it be a supportive network and not just an isolated relationship that starts and stops in one place, but rather is linked together in a meaningful way. And so again, this is part of what we do to establish and ensure that referral pathway from the pediatric office into the community. All right, so with that, that's a brief description of the local networks of care. And now I'd like to pass back to Kitty Bailey to talk more about the learning community opportunities.
Thanks, Lori. Thanks, Dr. Gilani, for your great talks. And I look forward to sharing a little bit about what we're doing and the way we're thinking about networks of care. And then just wanted to encourage everybody, we have so many participants. I just want to thank everybody for choosing to come to this talk and learn more about ACEs and networks of care. We're at 169 participants right now. And now would be a great time to start thinking about the questions you might want to pose to the speakers, and go ahead and put those in the Q&A box. I think I might have seen somebody raise their hand. I'm not sure I have the capabilities to address raised hands. So my recommendation based on what we heard was to go ahead and put your questions in the Q&A box for us, because I'm not sure I can call on people, just FYI. So again, I'm Kitty Bailey. I'm the executive director of the San Diego Accountable Community for Health. I wear a couple of hats as well. Many of you know me as well for the role I play with Be There San Diego, and also the role we play with Neighborhood Networks. But today we're really going to focus in on the work we're doing as the Accountable Community for Health, and how the Accountable Community for Health is really wanting to approach this work around creating a network, a trauma-informed network of care for adverse childhood experiences. First, let's start off with what is the accountable community for health? Well, we've been at this work since 2016. So many of you, I'm sure, have been to at least one of our meetings as the accountable community for health. But we exist to bring together partners. That's the whole reason why the accountable community for health exists. It exists because we believe that creating true health outcomes, and that we really want to see both at an individual and community level, is no one organization, no one sector's responsibility. It's all of our responsibility. It's all of us working together. We have to share responsibility and share accountability for these shared outcomes we want to get. And so to do that, you need a framework, you need a table, you need a place to come together and have hard discussions and build trust. And so that's what we do at the ACH. We work with partners across multiple sectors. We are trying, honestly, to redefine the local health system so that it's not seen as just clinical settings. It's not just seen as the four walls of a building where you go and get primary care or specialty care. It's really seen as what happens after you leave those four walls. It's the schools, it's the institutions, it's the small businesses, it's the parks. So many community factors go into creating health and wellness. And that is really the whole reason why we bring partners together. So the ACH, we have a dedicated group of partners. So everybody who's on this, participating in this talk, we appreciate you for your commitment to the ACH. If anybody wants to get involved in the ACH, the invitation is open. Today we have over 100 committed stakeholders working across many work groups on many different projects. But I would say if I have to pick a lane, if you guys are like, Kitty, I want to know what is your lane, because we have a lot of cross-sector partnerships going on in San Diego. I would pick community clinical linkages. And that's really what we're all about, is how do we create effective community clinical linkages to get the outcomes we want of community health wellness, as well as individuals thriving with better health. So moving into the next slide. So all of what I just said was important because it really informs the way we've started thinking about a network of care as defined by the ACEs Aware Initiative. And they've actually adopted some new language. I now hear them calling it the trauma-informed network of care. So when we thought about how are we going to go about as San Diego building a strong vision for a future where we have a comprehensive way of addressing these ACEs in our populations. This can include children, but it also, as Pradeep mentioned, we should be thinking about this as all populations, inclusive of adults. We really need to change the way we think about social problems. Clearly ACEs are an intergenerational cycle that needs to be broken, and that's not simple work. That's complex work, and we have to start thinking in new ways about how we break those intergenerational cycles by working together and not doing business as usual or we've done in the past with a very mechanistic point of view around how problems get created and how problems get solved. And so that new way of thinking about it is really what up until now has been started to be the field of systems thinking. And so we want to utilize systems thinking as we approach this work. No system can do this alone. Systems are interconnected, and only by addressing the interconnections between the various sectors and between the community and the recipients of care are we really able to create true change. And we need to have a collective understanding and commitment to changing culture. So we can create all the best workflows, we could create really fantastic referral networks, but if we don't as a culture change our point of view and the way we think about this work, we really won't create lasting change that really impacts that intergenerational cycle. So what we're going to be working on as the Accountable Community for Health is creating a learning collaborative where we will work together with our partners to really learn from each other. And as so many of you on this call know already, this always starts with building relationships and trust. That is a lot of the work we do day in and day out. And so we see these three sectors coming together: healthcare, social services, community, really coming together and having new kinds of conversations and building relationships and trust as just a foundation and starting point. We want to be able to identify and address each other's challenges and the challenge of working together in new ways to be supportive of families, children, and individuals. We believe there's a tremendous amount of skill, talent, resources, knowledge that exists already in these three sectors. And we really want to elevate those and have the different sectors learn from each other about what those best practices that already exist are. And I would say first and foremost in that conversation, we start with the community. What are the skills, resources, and treasure, as my good friend Elizabeth Bustos likes to say, already exists in the community that we want to elevate and build upon? And I believe we want to generate a vision for a future where we prevent and treat ACEs through a robust network of care, but not just treating individuals, also creating new systems for intergenerational impacts, where we no longer have to address individual ACEs because we've just prevented them from happening in the first place. In terms of this learning collaborative, we are going to be working towards building in the first quarter of 2021. We have some clear outcomes that we can come back to you all, hopefully a year from now, and talk to you about what we've been able to create. We believe we need to start with creating an inventory of those protective factors that include both traditional and what we would think of established kind of community resources, and more innovative and maybe not normally thought of as a protective factor, or not normally would be on a list of referrals. What are those types of things, and how do we elevate them and include them as we think about solutions moving forward? Of course, one of our objectives is to increase awareness and understanding between the sectors so that they really can say that they understand what it feels like to be in the shoes of somebody from a different sector. They can really understand what are the challenges, what are the inspirations of that other sector, and what do they want to see as a part of this. And then identifying those best practices. And I think what we really will be able to come up with is an inventory of best practices on how each of these sectors can participate in a future vision at a global level for San Diego County of a true network of care. And with that, we are going to move on to the part of our agenda related to questions and answers. So I appreciate everybody listening to these presentations. And I think what I'm gonna do now is these are your speakers. Just as a reminder, I want everybody to write down any of these emails you want, because I think I'm going to stop sharing my screen and ask the other two presenters to go ahead and turn your video and audio back on, and then I will try to field questions from both the chat box or the Q&A box. So I'm going to stop sharing, and hopefully now you're seeing all of us as your speaker panel. And I'm going to go ahead and take a look and see what we've got. So I think one of the questions we had here that was for Pradeep, it was related to how the pandemic might be impacting the current ACEs and the scores that we might be seeing in these through these new screenings that are happening.
It's a great question. I think when we look at the pandemic, there's a couple of ways people have been thinking about it. A lot of folks have been saying collectively we have a collective shared trauma. I think it's really important to distinguish the fact that the adverse childhood experiences really end up impacting the way that we develop. And so developmental trauma is a very important and very specific way of thinking about things. That said, all of us are significantly impacted by the stress of the COVID-19 situation, and our families who have less resources. And again, Lori did such a wonderful job talking about the protective factors. And so families that have less protective factors are going to be more impacted. The economic impact is as significant as the health impact. There's just a lot of fear. There's a lot of anxiety. Any of you who have school-aged kids who are now teachers in addition to working, everybody's at home together. There's a number of stressors that are impacting all of us. And so again, I think it's really important for us to reach out for our supports. I myself run several groups where I just do some reflective work with my frontline providers who are doing a great job supporting families. but they need support as well. And they're facing a lot of stress. And so some weeks things are going well and some weeks things are hard, and it ebbs and flows. And I don't think there's any one size fits all. But we talk every week, or I'm sorry, we talk right now, it's every other week. At the beginning of the pandemic, we talked every week just to see where people are at. And we all need help with our regulation. Regulation is that ability to manage our thoughts, our sensations, and our emotions. And again, the whole concept of self-regulation is important, but we also have the process of co-regulation, which is we help regulate one another. And so regulating relationships really bring us some strength. And we need to do things like take walks, take care of our physical bodies. Those self-care pieces that I mentioned are true for all of us, and particularly in this time of crisis.
So I'd like to speak to that also
Yeah,
from the community standpoint, just to say a little bit as well. And part of what we recognized with the coronavirus pandemic is that the infrastructure and connection of community-based organizations was such a vital resource to families. For example, and thank goodness we have a trauma-informed governor here in California who early on in March allocated $3 million statewide, not a whole lot of money, but Band-Aid money for families before stimulus came through. And that was administered through family resource centers, which are a part of the community-based organization networks. And the hallmark of CBOs and FRCs are that they are already established in the community and they have trusting relationships with folks in the community. So they are a go-to for information on what to do, where to go, how to get those needs met. And we were very pleased that community-based organizations didn't shut their doors and go home when the coronavirus came on, but rather looked at themselves as vital responders to serving families and serving the communities in a safe way, and became very innovative. So community-based organizations help to bridge the digital divide in ensuring that kids had devices, that families had access to the internet to get information, to have those social connections. So a myriad of ways that the trusted community entity also was able to come around kids and families at such a critical time. And so part of it is that we need it in place for such a time as that. And it was very gratifying to see some of the community response that came through that. And of course, some of the innovation and doing things differently because the circumstances required a different kind of response.
Great, thank you. This question was written in the chat box. Pradeep and then Lori, of course, jump in. Can you talk about the intersection between ACEs and experiences of racism?
Oh, yeah. So I have been talking about the ACEs for quite a while now. And right off the bat, the first thing that struck me was at that time when this study was done, there was no accounting for historical trauma, institutional racism. I think it's really important to acknowledge that. And if we looked at it from a different perspective, which is what are the health outcomes for different ethnic groups that have suffered from institutional racism? So when I look at Native Americans, I would say that they automatically get a bump in their score of 4 to 5. If I look at the health outcomes, there's significant impact in Native American communities. And when we look at policies, particularly policies from our own federal government that actually destroyed family and culture. If you have not heard about Indian schools, it is not a good thing. It was taking children from reservations and really trying to, quote unquote, take the native out of them and really destroying culture and family. Very horrific part of our collective history in America that we need to actually atone for. Likewise with slavery, breakdown of the family, a destruction of the family, policies around welfare and having men at home, redlining in terms of housing. Wendy Ellis does a beautiful job, and I know that Lori and the SDSU Policy Center have done work around resilient communities and the PARABASES, which is adverse community environments. And so there's an interplay between adverse childhood experiences and adverse, communities, the impacting communities. And so very, very powerful piece, and something we need to look at. And, when I look at the health outcomes for African Americans and the impacts of institutional systemic racism, I think the ACEs score gets bumped up by 3 or 4 automatically. And again, when we look at things like infant mortality rates, there's still a persistence in the difference in African American women's infant mortality rates compared to Caucasian women. Now, there's been an improvement overall, but there's still a gigantic gap. And so, again, as we look at it, I think we're at an incredible point as a community, as a society, that we're actually addressing some of these issues that have been there. And that work has, there's a lot of work to be done to level the playing field and to really live up to the promise of America for the equality of all. And I know, Laura, you have some thoughts about this as well.
Yeah, thank you. I do. And thank you for mentioning the toolkit that we developed on building community resilience. It's posted on our website. So if that's of interest to anybody, please feel free to reach out and take a look at a copy of that. Part of what we've been thinking about more so lately in terms of this question, the impact of racism on trauma or vice versa, is just a simple acknowledgement that we know that communities of color, particularly African American and Latinx population and others, are disproportionately impacted by adverse childhood experiences, by trauma, including historical trauma. And so part of what is emerging in the community-based practice and relationships is that it's not enough to just be generic in being trauma informed, but that we have to know and name and work with the impact of trauma from the racial perspective, from systemic racism, from historical trauma. So for example, understanding that trauma isn't just a generic set of adverse childhood experiences, but it involves deep felt devaluation, an altered sense of self, and having a voicelessness as a few examples of that. So again, as we think through and understand and better communicate with each other, we're better able to take that deeper in a more specific way that, again, is not just doing something generic on the surface, but has real and targeted implications for the hope that you were talking about earlier, Pradeep, for doing things in a different and meaningful and intentional and targeted way that create that regenerative process and build resiliency.
Great, thank you. Maybe Laura, you could start off on this question and then I'll jump in. The question is, and I'm going to group 2 questions together. Do you provide avenues for community-based conversations on this topic? Many people want to better understand how to reduce this cycle in the community. And then I'll tag on another question, which is, are you interested in working with senior groups?
Well, thank you very much for the questions across the board, everybody. Let me say these are great questions and gives us an opportunity to think more and to dialogue with you. So I appreciate that. At the Social Policy Institute and within our partnership, we're all about facilitating these kinds of conversations on an ongoing basis. And we do that in a number of avenues. And we're always looking to bridge that so that there is diversity, equity, and inclusion in everything that we're doing. And very importantly, that we map the dots between these so that everyone who wants to be a part of the dialogue, a part of the solution, has a place to fit and belong and contribute, because we need everyone in the community doing that. So I'm going to skip ahead to my punchline and say that we can't talk about network of care without naming that all of you are a part of it. And so we want to see and find that role for each person. So yes, we facilitate that dialogue in each of the different activities that we're involved with. And a part of our insight is that it's not Social Policy Institute specific, it's not American Academy of Pediatrics specific, it's not Accountable Communities for Health, but it's really bringing the dialogue and coming together where it makes sense to fit. And I know that Kitty's going to talk more about that. One of our partners who's not here today is the YMCA, who is the federal grantee, one of 9 in the country, who is initiating Partners for Prevention in San Diego, which is one form of network here. And they've done great work in really inviting an inclusive dialogue. And I'm happy that we're part of that together. So Kitty, what are your thoughts on the same?
Yeah, I was just putting in the chat box, and maybe, I don't know if Lori and Pradeep, you can also put in the chat box your emails. So in the chat box, and I hope everybody on we're at 160 participants still can see the chat box and get access to those emails. But I was going to suggest that anybody who wants to be a part of the conversation we're having around ACEs and the network of care at the Accountable Community for Health, we do a quarterly, what we call stakeholders meeting. So please go ahead and send me an email and I'll add you to our email list. Lori and Pradeep can put their emails in there. And at the end, in a couple minutes, I will also, actually, I'll go ahead and share my screen right now, and we'll do this a couple ways so people can have access to emails in a couple ways. Here we go. So you're seeing our faces, but now hopefully you'll also see the slide that has our emails on it. Having said that, we at the Accountable Community for Health are happy to have as many partners at the table, because it is the richness of all the voices coming together. And one of the things we really pride ourselves on at the Accountable Community for Health is having courageous conversations where, you know, talking about race and talking about racism, talking about trauma, you know, these are hard conversations to have some time, and to be able to have them with across sectors, where you're sitting at a table with people you haven't met before who are not from the same sector as you, and maybe those are hard conversations. But hopefully what we're doing in all of the work that's been described today is being able to create safe places to have those kinds of conversations. And that really is what it takes, I think, to make lasting change.
Kitty, I'd like to add one thought, if I may. Part of your question to me was about how we connect older adults in the effort as well. And so I wanted to just add that to the broad network and say that not only should our conversations be transparent and inclusive, but that should be across the lifespan. There is a vibrant movement in San Diego for age well, live within the live well family. And a part of that is building age-friendly communities. We're also a part of that work. And whenever we talk to older adults about what they want for the community, they're the first to say, not just for us, for people of all ages. And so I think as we link that opportunity to come together and to be innovative and to knit resources, it's going to create a really wonderful opportunity for more of an intergenerational impact in the work in building a network of care.
Great, thank you. This question is related to how many pediatricians are actively screening for ACEs now and or in the near future? And when will this be coming to a pediatrician in your neighborhood kind of question? When, you know, because you can imagine these might start to raise some questions in just, you know, the public's mind. So I don't know, Pradeep or Laura, if you have a sense. I know I have had some conversations, but I think Pradeep, you might, as from the AAP, might have the best answer.
Yeah, so we are doing it's really interesting. Some of my colleagues have been way out in front. We have folks that have been screening for 3 or 4 years, really doing an amazing job of connecting families and really thinking through what do families need and want. We are in the process of getting more offices to do this. And again, it's one of those pieces where each of the offices really, it's going to take time based on their readiness. Not only are we at the American Academy of Pediatrics doing work locally, our colleagues at UCSD have been doing some work as well. North County Health Services, which is now True Care, I think is their name. Some of our colleagues there have been really doing this work for several years. And Ken Morris, who is a pediatrician and a great leader in the community, has moved over to CPCMG and is doing some work there as well to get their offices screening. So this will become more common. And I think one of the pieces that's really important, and this is something that Kitty, you and your group has talked about as well as I know Blanca Menendez at the Obesity Initiative in UCSD has talked about, how does the community want us to talk about this? And so again, people don't want to come up, people don't want us to say, hi, how are you? What are your traumas? They actually want conversation about what's been difficult in your life and how can we help you? And again, the pediatrician's office is such a wonderful place for this to happen. But again, this is in addition to all the work that pediatricians already do. So again, we need to support our pediatric colleagues in making sure that this is done by the office collectively, and we normalize it and we make it easy for all families to get these resources. Again, I don't want this image of it being one part of our community. That initial study that Vincent Felitti did was with a Kaiser population. So we can look at a employed middle-class population that had a high number of adverse childhood experiences. So again, this is something we all need to look at.
Great. Thank you. I see we have a 5-minute warning, and I'm just perusing the chat box and the Q&A box to look for additional questions, because I think I've seen a couple that we have not gotten to. So maybe we can spend time on just 2 more questions once I find them.
And as Kitty's looking for that, again, I want to echo what Lori said earlier, that the questions that folks have asked are wonderful. They are really show a real a good understanding of what community needs are, and you really do enhance our work by asking great questions.
Here's a question. This must be from somebody who's working in a school district, because the question is related to how can schools become a part of this network of care? What would their role be in the network of care?
So I'll start that off and invite my colleagues to add to that as well. Our partners from education are just such important and critical partners. The idea here is that it's the community approach, it's a cross-sector approach. Kitty, you brought this up initially, that there are established supports and there's innovative informal ones. And so part of, I think, our opportunity in knitting together a network of care is to have those dialogues and conversations about where do we respectively play a part and how can we interact together to be a seamless network. But certainly understanding the referral pathway, making that intentional, bringing it to the surface. Education is a critical partner in every effort that we engage in. And so really appreciate the question, and so are other sectors as well. I'm fully convinced everyone has a role to play in that. Specifically, education, you know, depending on the role and the opportunity, can also be one to recognize the impact of trauma or recognize potentially the presence of ACEs, and also to facilitate support or referral around that. That's just one way, but that's a very concrete part of it.
Thank you, Lori. That was great. We have 2 more minutes left, and we have 2 minutes left, and I just, I think it would be helpful to, I don't know, Lori or Pradeep, if you have any input on the role of data exchange or the community information exchange, but I know that they're, you know, one of our biggest assets here in San Diego, and can speak to how the CIE might be a part of a network of care. I know that's something we're looking at very closely, and one of our, we've subcontracted one of our grant projects, a white paper, to 211's CIE, so that they can start to do some study and research and thinking about how does the CIE actively become a part of a robust network of care approach we take here in San Diego as a holistic approach. So it's something that they are receiving a sub grant to our grant around. But I don't know, Lori or Pradeep, if you had anything else to add.
Sure, I'll just say for me that part of a network of care is really recognizing the family experience in that network. We know that families don't want to be passed from one provider to another to another. They don't want to tell their story again and again. So just at that level, if nothing else, the role of data linkage and information sharing helps us to become a blended, united network that makes the family experience and care coordination efficient and a good fit for families that's engaging and meaningful and meets their needs.
And that's 2 o'clock, and I know they're ending our session. So thank you, everybody, and thank you to our speakers. Bye-bye.
Thank you. Bye.